Good afternoon, dear colleagues. I'm Dr. Patrick Rossignol from Monaco. It's my privilege to welcome you to this webinar entitled Heart Failure in Patients with CKD, Diagnosis and Therapeutic Approaches. This webinar is organized by the EuReCa-M Working Group from ERA. I was privileged to serve on this board a couple of years ago. Today, we have an outstanding faculty panel encompassing one speaker, Charlie Ferro from UK, two panelists, Evangelia and Ntounousi from Greece, Lucia del Vecchio, Italy. Of course, I will be proud to moderate this session. This will be a 1-hour session, and I wish I may share with you few information. First of all, I wish I may mention that ERA is launching a real-time translation, both audio and captions, with artificial intelligence in 7 languages: French, German, Italian, Portuguese, Russian, Spanish, and Turkish. To enable the audio, please click on the globe icon at the bottom near the pause function and choose your language. For the captions, an external link to access through the browser will be provided within the chat. Another information I wish I may share with you relates to credits. By participating live, participants will earn 1 European credit for their continuous medical education. This is an exclusive benefit for active ERA members only. To get the diploma, attendees must fill in the mandatory questionnaire feedback at the end of the e-seminar. That said, I'm proud to introduce you our speaker, Charlie Ferro. Please, Charlie.
Thanks, Patrick. It's a great honor to be able to present on behalf of EuReCa-M. This is my 6th year and final year as vice chairman. It's been a great honor and privilege to serve. These are my declarations of interest. And we start with a bit of the epidemiology of heart failure. The diagnosis varies across countries hugely, but I think it's probably fair to say that somewhere between 1 and 4 or 5% of the population will be affected by heart failure at any one time. And of course, the incidence increases with age, very much like it does with CKD. And indeed, heart failure and chronic kidney disease share many of the same risk factors, and the etiologies overlap. So it's not a surprise that both coexist in a large number of patients. So here we have data from the US Renal Data Service, the 2020 report, which looks at data from 2018. In the second panel, we have heart failure taken from the US RDS, affecting about 3–4% of the population of age over 66 in America, and much commoner in CKD, even at stages 1 to 2, and increases proportionally up to CKD stages 4 or 5. So in America, if you're aged over 66 and you have CKD stage 4 or 5, you've almost got a 40–45% chance of having heart failure as well. And the proportion is indeed the same in dialysis patients. So in America, all comers, not just age over 66, will have a dialysis patients will have over a 40% chance of having heart failure. Less so in peritoneal dialysis patients, but remember, I don't think this is necessarily related to PD itself, but more than the population are usually healthier and younger. And of course, even in transplant patients who've been exposed to dialysis, they have a 20% chance of having heart failure. And it's not just about co-location of the two pathologies. It's actually worse than that. So if you have heart failure in America and you're age over 66, it's associated with a huge mortality of about 70–75% at 2 years. If on top of that, you've also got CKD 4 and 5, the mortality is up to 50% in 2 years. Quite a horrendous statistic. And if you look at dialysis patients, hemodialysis patients with heart failure will have a 40% chance of being dead at 2 years. These are pretty horrific statistics, and it's what we see in our daily practice. So the simple plan for the next 20 minutes or so is I'm going to talk a bit about how we make the diagnosis of heart failure, how the classification of heart failure, and treatment. And I'm going to confine myself to treatment to mainly the 4 pillars as described in the European Society of Cardiology guidelines on heart failure, and a bit about iron at the end. I'm not going to talk about devices, and I'm not going to talk about some of the newer treatments that are coming on. When I first set out the plan for this talk towards the end of last year, it was about 3 to 3.5 hours long. So I've had to keep it confined. So apologies for that, but maybe a lot of the issues, if of interest to people, we can bring out to the discussion later on with the panelists and moderator. So we start off with the diagnosis. Symptoms and signs are there to give us an indication that we might be dealing with heart failure. So breathlessness on exertion, fatigue, ankle swelling, a raised jugular venous pressure, peripheral edema are all give us a clue that we might be dealing with heart failure. However, they're very non-specific, and they're very common in the general population and even more common in patients with CKD and end-stage kidney disease. So remember in the mid-90s at meetings, people were talking about heart failure in dialysis, and that usually prompted a huge argument, and people were arguing whether or not it was true heart failure or just purely fluid overload. I think some of those arguments still continue to this day, but hopefully not as aggressive as they used to be. Alone, symptoms and signs cannot be used to make a diagnosis. This is the algorithm for heart failure diagnosis as illustrated in the ESC guidelines in 2021. If you suspect heart failure, first thing to do is an ECG, followed by measuring of brain natriuretic peptide, either the full form or the N-terminal pro version. Most of us in Europe now, hopefully, will have unrestricted access, or at least easy access to echocardiography, and that's where the diagnosis is really made, and the classification. And we'll talk about that a bit later on through the talk. It's important to mention that an ECG cannot be normal and the patient have heart failure. That just does not happen. My nephrology colleagues still get exasperated whenever they talk to me about a particular patient and I ask to see the ECG. You must remember it's still very cheap and extremely useful. Brain natriuretic peptide is a new step, so a level of BNP of less than 35 picograms per millimole, or an NT-pro BNP of less than 125 picograms per millimole makes a diagnosis of heart failure unlikely. It's a negative predictive value of 94 to 98%. So one of these 2 criteria is not met. It's a 1 in 20 chance that the patient will have heart failure. So a pretty good diagnostic test, really. The magnitude of elevation is a prognostic value, so it's important to not just to know if it's high or not by how high. And of course, also important to remember that there are other causes of BNP elevation, such as they'll be higher in atrial fibrillation and left ventricular hypertrophy, and sometimes laboratories will code different cutoff values depending if these conditions exist or not. Having renal dysfunction or chronic kidney disease increases the levels of BNP, but this, however, thankfully varies minimally with eGFRs more than 30 mils per minute. Well, people are raising their hands. Does that mean can you still see my screen and hear me?
Well, that's fine, Charlie. Yeah,
okay.
Go ahead.
Sorry, no, just worried that people were raising their hands again and I'd been cut off again.
I will let you know if there is a new issue, Charles. Please, go ahead.
The adrenalines are running high. In dialysis patients, we cannot make a diagnosis of heart failure using BNP or NT-proBNP. They are often extremely raised, not just because of heart failure. They are, however, of interest of great prognostic value. So levels of about 15,000 picograms per millimole means the risk of cardiovascular mortality is 5 times higher than levels of less than 2,000. So next, once we still think that our patient's heart failure, we move on to do an echocardiogram. And as I said, hopefully this is now fairly easily available throughout Europe. And the classification of heart failure really boils down to 3 types. There's the one we all grew up with and are used to, so systolic dysfunction. So we call that now heart failure with reduced ejection fraction. The ejection fraction is less than or equal to 40%. There's a heart failure with mildly reduced ejection fraction, which is a new terminology. It's previously called mid-range, and that's between 41 and 49%. And the terminology has been changed to emphasize that these patients still have heart failure and should probably be treated as if they had reduced ejection fraction. It's also there to reflect the fact that the error margin is about 5% when measuring ejection fraction with echocardiography. And then, of course, there's our old friend, heart failure with preserved ejection fraction, where the ejection fraction is essentially normal and greater than equal to 50%. This is just to illustrate that most patients will have either reduced or preserved ejection fraction. Here, mid-range ejection fraction is called borderline. This is an old paper in 2017. But if you look at the mortality, readmission, cardiovascular readmission, heart failure readmission, they're all very similar, regardless of which form of heart failure you have. So for the diagnosis of heart failure with preserved ejection fraction, it's difficult, it's challenging, it's controversial. There has to be, in addition to a raised BNP, some objective evidence of cardiac structural and functional abnormality consistent with left ventricular diastolic dysfunction and/or raised left ventricular filling pressures. So there is debate. There is no clear marker of what constitutes diastolic dysfunction or is acceptable for heart failure preserved ejection fraction. Normally, we rely on having at least one or more of these markers, such as left ventricular mass index, so by definition, left ventricular hypertrophy. Although it's reassuring to have patients with left ventricular hypertrophy, making the diagnosis of HFpEF a bit likelier is not essential. The same for relative wall thickness. One of the commonest used is having a distended left atrium or left atrial volume index of greater than 34 mils per meter squared. In atrial fibrillation, threshold slightly higher at 40 mils per meter squared. E over E prime is probably the one that my cardiology colleagues rely on most. So a ratio of more than 9 has a 78% sensitivity. That means that it picks up most patients, but it's not very specific, will overdiagnose in a lot. Similarly, if we move the threshold up to 13, the sensitivity goes down to 46%, but the specificity goes up to 86%. Pulmonary hypertension and TR velocity arrest are also good markers, but none of them are categorical. As I said, we normally rely on having 1, 2, and hopefully 3 of these markers to be confident of the diagnosis of heart failure with preserved ejection fraction. So moving on to heart failure treatment in drugs. We start off with heart failure with reduced ejection fraction. And I'm going to talk about essentially the 4 pillars: SGLT2 inhibitors, ACE inhibitors, angiotensin receptor blockers, and angiotensin receptors and neprilysin inhibitors, beta blockers, and MRAs. And I've illustrated this here that 3 out of those 4 are actually very important treatments for chronic kidney disease to prevent progression and improve outcomes. Again, emphasizing the connection between the 2 conditions. So we started with beta blockers. It's coming up to 30 years since, if not longer, since the first beta blocker trials in heart failure were out there. I'm using this one because it reminds me of when I became a medical fellow at a district general hospital in the United Kingdom, having been working in teaching hospitals in cardiology. And I remember one medical take I performed where I admitted 2 patients with decompensated heart failure, and I did not stop the beta blockers on these patients. And the cardiologist nearly marched me out of the hospital and threatened to throw me out of medicine. He never apologized for that, because we now well know, and then we did know as well, that beta blockers are actually quite good for heart failure. And before my time was up in that district general, we had set up specific clinics to initiate beta blockers in patients with heart failure. So it just goes to show what a time lag there is between evidence becoming available and that translating directly into medical practice. Nowadays, nobody would think that it was wrong to start a beta blocker or indeed stop a beta blocker in a patient with heart failure. Well, I thought I'd use this paper by our chairman, Patrick Rossignol, today to illustrate that we also now know from sub-studies of many studies of beta blockers in heart failure that their efficacy does not seem to be affected by renal function, certainly not by eGFRs down to 30 mils per minute, and probably not even when the GFR falls below that. So in CKD, beta blockers in heart failure are a good thing. There's this intriguing study from Italy by Cicce et al. In 2003. It's the only randomized controlled trial of beta blockers in dialysis patients that I know of. So it's placebo-controlled, small number of patients, 114. And there's a few unusual things about it. So patients were dialyzed 4 times a week for 3 to 4 hours. I would struggle to do that with my patients in the UK or indeed anywhere in the Western Hemisphere that I know of. And pretty much all the patients before being randomized were on an ACE inhibitor or an angiotensin receptor blocker. Again, a lot of my patients struggle to take these, particularly if they have heart failure. Interesting, carvedilol was associated with much lower rates of hospital admissions and improved cardiovascular and all-cause mortality, as well as improvements in left ventricular function. And if you look at the graph quite carefully, by the end of 2 years, if they weren't taking carvedilol, 70% of the patients of the control group were dead, and 50% in taking carvedilol were dead, again emphasizing the horrific mortality that these two conditions combined have. Moving on to the second pillar, the angiotensin converting enzyme inhibitors, ARBs, and ARNis. Again, I'm showing old data, and apologies coming through a bit blurred. It's now coming up to 40 years since we've learned that ACE inhibitors and angiotensin receptor blockers are a good thing and improve mortality in heart failure. And this one is enalapril, it's probably the second available ACE inhibitor. There is consistent heterogeneity, no heterogeneity in outcomes between CKD and and outcomes when patients with CKD or non-CKD. Again, although many of the trials have excluded patients with eGFRs less than 30, but it's consistent that ACE inhibitors are a good thing and improve outcomes in patients with chronic kidney disease, probably at all levels. There are no randomized controlled trials of any significance using ACE inhibitors or ARBs in dialysis. Observational studies are interesting, and they're very similar to the beta blocker observational studies in that you can usually find whatever you want to find. So you can find trials, observational studies which show improved survival, no improvement in survival, or decreased survival or mortality with using of these agents. And I think we've always got to be careful with observational dialysis studies because they're heavily confounded by the patient willingness to take the medication, or indeed the patient's ability to take the medication without collapsing their blood pressure or tolerating fluid removal on dialysis. So it often is a marker of patient wellness, in my opinion. There is also a very intriguing study in hemodialysis patients done by the same group, led by Cicce et al. It's not a trial of an angiotensin receptor blocker in dialysis. It's a trial of the addition of telmisartan, an angiotensin receptor blocker, into patients already treated with an ACE inhibitor. And this time, there's 332 patients across Italy randomized, double-blind placebo-controlled, with an ejection fraction of less than 40%. And again, all patients were on 4 times weekly dialysis. 100% were on an ACE inhibitor, and 60% of them were also on carvedilol, so on optimal treatment. And despite that, telmisartan had very significant improvements in all-cause mortality and lower rates of hospital admissions, and improvements in cardiovascular mortality and increase in left ventricular ejection fraction. It's a study that hasn't been replicated or done again, but it's very, very interesting. ARNis are sort of the new kids on the block in this field of inhibition of the renal angiotensin system and NEP inhibition. And in patients taking enalapril, regardless of their renal function, or at least with eGFRs down to 30%, it improves outcomes, usually the composite of CV, cardiovascular death, and hospitalization for heart failure. So if you have enalapril and no CKD, that's the best outcome. And if you have enalapril and with the addition of an ARNi instead of enalapril, your outcomes are even better whether you have CKD or not CKD. There are no randomized controlled trials of ARNis in dialysis patients. Observational studies are even more confused and confounded, with showing conflicting effects on mortality and heart failure hospitalizations. And indeed, one study showed that dialysis patients treated with ARNis had an increase in mortality and heart failure hospitalizations, which is difficult to understand, but that's the data of observational studies, and again has to be taken very, very skeptically. Moving on to mineralocorticoid receptor antagonists. We're talking about not 30 and 40 years, but more into the 20 years now, since Rails was published in the New England Journal. Severe heart failure with reduced ejection fraction and a 30% risk reduction with the addition of low-dose spironolactone. Replicate again in Theseus with not as impaired left ventricular function, but post-myocardial infarction, and in emphasis confirmed what we knew from the previous two studies. But now MRAs are well-established treatment for heart failure in the general population. Because of their effect on renal function and the risk of hyperkalemia, there's been multiple sub-analyses of pretty much all the major MRA trials, and all of them confirm that in eGFRs less than 60, MRAs improve survival in all-cause mortality, cardiovascular mortality, and heart failure admissions. With eGFRs below 60, most of the trials have excluded patients with very severely impaired renal function, but up to about 20 to 30 mils per minute, the benefit still stands. And that is true for Rails, and is also true for emphasis, and is also true for Theseus. There are no randomized controlled trials of MRAs in dialysis patients of any great number to make any decisions from. There's this one observational study just published at almost on the same day that I heard I was giving this talk, from Taiwan, where they had over 2,000 patients on hemodialysis with heart failure, and they were matched to 3 different other patients with heart failure not taking mineralocorticoid receptor antagonists. And they did demonstrate a clear improvement in survival. You can see between the red and the blue lines, there is clear space with the lines diverging at about a year. However, the effect is not huge. And as I said, I'm always very skeptical of observational studies on medication in dialysis patients, because some of it is reflecting medication. Some of it's also reflecting patient selection and patient's ability to take medication. Our chairman, Patrick, is leading Alchemist, which is a study of spironolactone in high-risk cardiovascular patients, but it's not a study of heart failure per se. And in the UK and in Canada and several other countries across the world, ACEi is looking at spironolactone in dialysis patients. Again, a high risk of cardiovascular events, but not specifically in heart failure patients. These two studies might shed a light on whether these agents are useful in heart failure or not. But we'll wait and see what the outcomes are. Moving on to the really new kids on the block, the wonder child that can do no wrong, the 2 inhibitors. And there are now a few studies of SGLT2 inhibitors in heart failure. In the middle of the panel, there's a reduced ejection fraction, which is what we're currently talking about, DAPA heart failure and EMPEROR reduced. And both of them reduce the combined composite endpoint of cardiovascular death or heart failure with hospitalization. But I must say, most of the events are heart failure hospitalization driving the positivity of these 2 studies. The same is true for those with minimally reduced ejection fraction and preserved ejection fraction seen at the top of the panel. but very, very successful, in addition to conventional therapy already. The actions of empagliflozin and indeed dapagliflozin do not appear to be affected by EGFR stages in CKD. And this is a pooled analysis of the EMPEROR studies and divided by the CKD high risk to low risk, depending on GFR and albuminuria. Improvements in outcomes were found across the board. There are no studies of SGLT2 inhibitors in heart failure and dialysis patients, as you would expect. There are a few safety and proof of concept studies going on at the moment, but none of them leading to hard outcomes, and definitely not in heart failure. So having talked about all these drugs and how they're really useful in chronic kidney disease, in what order should we start them? Well, the European Society of Cardiology gives quite clear guidelines, and they've moved to what we call the 4 by 4 weeks. So after a diagnosis of heart failures with reduced ejection fractions made, all drugs to be started within the 4 weeks at low dose. The order of introduction remains debatable, and I think very much will depend on the individual clinician's preference, but it moves away from the previous guideline, or we call the traditional recipe of 3 drugs, each one started individually, the dose optimized before the second drug, because we found that that was taking over 6 months to introduce 3 drugs and up titrate to recommended doses. The change was also done because data have consistently shown that the low dose of each of the 4 agents achieves greater benefits than observed with dose titration. The data has also consistently shown to benefit of each drug independent of each other, as you would expect given their different modes of action. And the benefit of each drug is apparent very quickly after initiation. It also, by using low doses of each drug and starting them quickly, improves safety and tolerability. The European Society of Cardiology also gives quite clear guidelines on what's acceptable in terms of effect in renal function. So an increase in serum creatinine of less than 50% above baseline, or as long as the serum creatinine remains above 226 micromoles per liter. Or you prefer to work in GFRs, a decrease of less than 10% from baseline is acceptable, as long as the GFR doesn't drop below 25 mils per minute. And I think that the reason for giving these guidelines is because we know a lot of these drugs will reduce kidney function, but that doesn't affect their prognostic benefit. It also tempers perhaps some enthusiasm of cardiologists or general physicians starting these drugs regardless of kidney function and their effect on. So it's trying to find a halfway house of not disadvantaging patients from receiving these drugs, but equally not going completely overboard and crazy and destroying the kidney function and putting them on dialysis or risking severe hyperkalemia. I think it's a decent compromise. Given, as I said, that many of these drugs are also beneficial for protecting kidney function, it made me think whether we should have a similar algorithm for CKD management. And this is probably particularly true for diabetic nephropathy, where we now have ACE inhibitors, angiotensin receptor blockers, SGLT2 inhibitors, and finerenone, on whether we should be aiming for a 3 drugs in 3 weeks kind of strategy in CKD. I think probably for the time being, probably not, given that all SGLT2 inhibitor trials and indeed finerenone trials all mandated maximum tolerated dose of ACE inhibitors and angiotensin receptor blockers before being randomized or starting these drugs. And then most SGLT, if not all, I think Patrick may be able to correct me, SGLT2 inhibitor trials have excluded patients on MRAs, although MRA trials of finerenone have allowed significant proportion of patients with SGLT2 inhibitors. But of course, remember the patients that we see in our kidney clinics are not the general population and therefore be at higher risk of hyperkalemia and renal function decline. So I think this approach would have to be tested first. So moving quickly on to heart failure with mild reduced ejection fraction. There are no dedicated trials in this population, and most of the data comes from observational studies and post-hoc analyses. There is clear benefit from the 3 old pillars, ACE inhibitors, ARBs, beta blockers, and MRAs. And there is emerging evidence of benefit from SGLT2 inhibitors For example, EPRA preserved, in which 30% of the 6,000 randomized patients had an ejection fraction of between 40 and 50%, and these patients did benefit from empagliflozin, both in terms of cardiovascular death and hospitalization for heart failure. So in general terms, we think this group of patients should be treated as having reduced ejection fraction. So heart failure with preserved ejection fraction, this is more of a bit of a heart sink. This is a network meta-analysis of placebo-controlled trials. And if you look at all-cause death, none of the main treatments, SGLT2 inhibitors, ARNis, MRAs, beta blockers, ARBs or ACE inhibitors, seem to affect all-cause mortality or indeed cardiovascular mortality, although perhaps there is a bit more positivity there in cardiovascular death. They do have quite significant impacts on hospitalization for heart failure, particularly with the SGLT2 inhibitors, ARNis, and MRAs. So a quick word about iron therapy for heart failure, because that's close to what we do in renal medicine. We're probably more adept at using iron than cardiologists and certainly general physicians. And this is an international pooled project of 1,500 patients with heart failure. And to a lot of people, iron deficiency immediately equates to anemia, and that is not the case. So if you look at this group, for example, not having iron deficiency and not having anemia as a reference group, being anemic but not without iron deficiency doesn't make much of an impact in all-cause mortality. Being iron deficient with no anemia does have an impact on all-cause mortality. It increases it, but having both iron deficiency and anemia is the worst possible combination, as probably would be accepted and biologically plausible. There's also probably little point in treating these patients with oral iron. Indeed, if they have a significant CKD, we know that iron, both absorption and utilization, is greatly impaired, and the benefit has to come from intravenous iron, in this case ferric carboxymaltose, improving both cardiovascular mortality, all-cause mortality, and hospitalization for heart failure. We now have a randomized controlled trial of high-dose IV iron given per protocol at high dose, as opposed to what we used to do, which is reactive low-dose iron regimen to replace iron deficiency. And although it's designed as a non-inferiority trial, it also showed superiority for the primary efficacy endpoint, which is all-cause mortality, non-fatal myocardial infarction, non-fatal stroke, and hospitalization for heart failure. But indeed, most of these events were actually driven by hospitalization for heart failure. During the iron therapy is probably protective for heart failure development and heart failure progression in our hemodialysis population. I'm very grateful to Lucia del Vecchio, who's one of the panelists in this meeting, and I was very proud to participate in this EuReCa-M joint collaboration where we wrote about the intravenous iron therapy and cardiovascular system risks and benefits. And of course, any questions, I'm sure Lucia is much better placed to answer them than I would be. So in summary, and I think I've stuck reasonably well to time given the anxious producing moments at the start of my talk, there are 4 pillars of treatment for heart failure with reduced ejection fraction, which should be treated the same for those with minimally reduced ejection fraction. And these are largely applicable for chronic kidney disease, at least with eGFRs down to 30 and possibly below that for some, particularly the SGLT2 inhibitors. There's very, very little evidence in dialysis patients, and that's probably being optimistic. I would say there's probably no evidence in dialysis patients of what we should be doing for heart failure. There's even less evidence for management of heart failure with preserved ejection fraction CKD, with absolutely no evidence whatsoever in dialysis patients. And these are urgent unmet needs to improve in the management of reduced ejection fraction heart failure in dialysis patients and in heart failure with preserved ejection fractions in all patients, including the general population and mild CKD. And with that, I'd like to thank you for your attention. And this is probably going to be my last event as the Vice Chairman of EuReCa-M, which I've served for 6 years, 9 years on the board. And I can tell you it's been a truly great honor and something that I'll greatly miss. And if anybody there is ever thinking about joining one of the working groups, I can tell you, please try, because you will really, really enjoy it. And with that, I'll finish and hand back over to a chairman. Thank you.
Thank you so much, Charlie. So this was once again a great talk, and thank you so much for all your contribution over the years for our EuReCa-M Working Group, Charlie. So it's now time for me to hand over to our two panelists. I may propose first to Evangelia to intervene.
Okay. Well, hello, good afternoon from me. It's a real pleasure to participate in this e-seminar with all the colleagues, with the other three colleagues. And well, I would like to thank Charlie for this excellent talk, very interesting summary and updated data. Really, thank you, Charlie. And actually, I would like to express my delight because since my first years in nephrology, around the beginning of the century, everybody said, well, our patients die through cardiovascular disease, and the severe stages of CKD, they die due to heart failure. So now, actually, we have entered a new era of treatment regarding our CKD patients, at least up to stage 4, and with reduced ejection fraction, heart failure with reduced ejection fraction, the worst status patients. And we have in our hands 4 different drug categories. The 4 pillars as guidelines and as Charlie said, and the newer drugs, SGLT2 and MRAs and actually finerenone, I think they have made the difference during the last year. So, and of course, iron, as Charlie said, iron has as well a place in our therapeutic as a therapeutic option. So, if I would like to emphasize 2 or 3 points, and at the end, I would like Charlie to comment on one of these. The first point is that we have huge number of patients. Huge number of patients, it's actually 800 million of CKD patients and 64 million of heart failure patients. And almost half of them of CKD, of heart failure patients, they have CKD. And you said that we have to go with these newer drugs up to eGFR of 25 or 20. I'm referring to empagliflozin. But what is your opinion about lower eGFR, about dialysis patients and about kidney transplant recipients patients? I know that there are no trials, but I would like your comment about these patients and your thoughts about these patients. And I'm referring to the cardiovascular protection and heart failure protection, because in these patients, we do not expect any benefit in the kidney function.
No, we really have very little trial evidence to guide us on this. If I can start with the kidney transplant patients, that's probably the easiest one to answer, I think. To me, kidney transplant patients are just chronic kidney disease patients with a bit of immunology and anti-rejection medication thrown in, and we should just treat them like CKD based on their EGFR. That's what I do. The trial evidence is not there, but I think that seems reasonable to me. In dialysis patients, I honestly don't know. My own practice reflects what my patients can tolerate. So if I know they've got heart failure, I think beta blockers are probably a good thing, but I know several of them, or not in fact, most of them can't tolerate beta blockers because they need the reflex tachycardia to cope with the stress of dialysis and the blood pressure reductions with dialysis. I try them on an ACE or an ARB. Hopefully the potassium holds and the blood pressure holds. And sometimes I'm brave enough to try mineralocorticoid receptor antagonists, usually spironolactone, mainly because I can't get finerenone paid for. And hope that that makes a difference, but I actually don't know if it makes a difference. That's the honest answer. There are large unmet needs for trials in dialysis patients. And I know Patrick is one of the pioneers, particularly with Alchemist, but I know he struggled with recruitment for many years, and hopefully it won't be long before we see Alchemist being reported. Does that answer your question?
Yes.
Any other topic you may wish to address, or should we hand over to Lucia, because we have a series of questions from the chat which we may wish to address.
No, I don't have anything else to say at this point. Maybe later, so that Lucia can comment as well.
Congratulations, Charles, for your brilliant presentation. I would like to make you a comment on SGLT2 inhibitors. It's now established that their effect in heart failure is not due simply by the fact that they are diuretics, but all other effects. However, it remains that they are diuretics, and they are diuretics with, let's say, peculiar characteristics compared to traditional diuretics. That is that they have less effect on increasing sympathetic activity, and they have a higher effect on the interstitial space compared to the intravascular space. And in your opinion, could these drugs somehow an agent that we can also use to restore the sensitivity to traditional diuretics in CKD patients?
Possibly. They do work. I think there's a very long list of how SGLT2 inhibitors could work and do work. And I think nobody's quite sure of what the whole benefit in terms of cardiovascular disease reduction is mediated by. They clearly are diuretics. There's no point in arguing. There was just a short study recently about how the body composition changes, as you were alluding to with SGLT2 inhibitors. They also change cardiac energetics. So they also change how the heart uses glucose preferentially to free fatty acids in states of disease, such as chronic kidney disease and heart failure. And indeed, there's a fantastically brilliant and brave study, I think it's in Austria, where they're looking at anuric dialysis patients and looking at SGLT2 inhibitors using cardiac MRI to see what changes happen in the heart. And I think that's a fantastic study. I wish I'd thought of that and had the energy to do that study. I think the short answer to your question is yes, SGLT2 inhibitors do everything well. I don't think I still have to find something that they do badly.
That's true.
They can seem to do no wrong.
Yeah.
Having said that, we always have to be careful with diuretic actions of drugs. And preparing for this talk reminded me of the worry and dangers there was with using ARNis in CKD patients. And part of that, I think, was actually mediated by the fact that in the general population, the dose of diuretics was reduced quite considerably after initiating patients on ARNis. And if you don't do that quickly in CKD, you will get a progression of chronic kidney disease and rapid deterioration. And I do wonder if SGLT2 inhibitors being used out of context of a randomized controlled trial, when people are carefully monitored and titrated, whether we might see the same effect start appearing in observational studies of possibly a decrease in renal function. Although having said that, they're so good at protecting renal function that it might counterbalance.
Yeah, it's also true that they somehow reduce the risk of acute renal failure compared to just simply ACE inhibitors. So from this point of view, they are safe.
Yeah, it's almost like arguing against mother's milk, arguing against SGLT2 inhibitors.
And I have a second comment. Yesterday, just on time, I made a consultation in the I made a consultation in the coronary unit for a patient, 69 years old, heart failure due to ischemic cardiopathy. And because of an acute event, the patient was halted all his medication. And the question of the consultation was, what agent I have to reintroduce and in which order? The patient was, before the acute event, was receiving everything, complete treatment, and his eGFR was around a little bit higher than 15. So I gave an answer, but I would like to know your opinion, because from one side, you rightly said that the drug for heart failure should be introduced, let's say, quickly. But when you have introduced many drugs and you have already severe kidney function, the answer is not so straightforward.
No, I agree. It's very easy to say you should start all 4 drugs and you should do them quickly. In our patients with advanced CKD, particularly those recovering from ACEi, it becomes tricky, doesn't it? I think the patient probably should end up on all the medication that we're on before, perhaps at reduced doses. We know that stopping drugs is associated with worse outcomes in heart failure and in CKD. And the worst thing we can do is not to reintroduce these drugs. The mortality is appalling, and it's often forgotten about. Patient gets discharged back to the family doctor, and these drugs are not, there's no clear plan for reintroduction. That's bad things happen then. I would, if I had to commit, I would probably go back on restart the drugs based on history. So ACE inhibitors first, angiotensin receptor blocker second, or an MRA third, and possibly the SGLT2 inhibitors towards the end. There is probably no logic, and I suspect people listening some of them might be rolling their eyes backwards. SGLT2 inhibitors probably have the best safety profile, so you could argue that they would be the ones to start first. But all SGLT2 inhibitor trials are on the background of maximal optimized doses of ACE inhibitors. So you could argue it both ways. I think the important thing is not to forget to restart the drugs, and which order and at what speed is probably the second point to consider.
And well, another comment I made myself when I was making the consultation, that the patient was followed in a very, very big cardiological center. And this could be observed by the fact that it was very, very highly medicated. He was receiving the possible best treatment. But then when he came in a, let's say, peripheral hospital with less experience and less, let's say, attitude to use aggressive treatment, the cardiologist stopped everything, first of all, and had the doubt of putting back treatment. They had no certainty on what they wanted to do. They were asking the nephrologist what to do.
Okay.
The right question of the consultation should have been, which kind of risk I have if I introduce this. Not leave to me the decision which kind of treatment for heart failure I have to reintroduce.
Yeah, that's reassuring in some ways. In my center, all our cardiologists are very much bought into starting all these drugs very quickly. And I've recently had a similar, well, it wasn't a consultation, I had to intervene uncalled for in one of my anuric dialysis patients on peritoneal dialysis, who'd actually cut down the peritoneal dialysis and had put on 10 kilograms in weight over 2 months, purely fluid. And happened to came in short of breath, had an echo which showed a 20% ejection fraction. And within hours, a plan was made for introduction of ARNis, mineralocorticoid receptor blocker, and SGLT2 inhibitor, and she was mapped for a ICD and resynchronization event. And I had to stop the cardiologist doing all this and just try and dry the patient out before they embarked on what's unproven potentially dangerous medication, certainly cardiac device, before any good evidence, what you'd be like when all the fluid had been removed. Yeah, so on the one hand, I'm keen to encourage cardiologists to use the evidence-based treatments in our patients. On the other hand, sometimes they have to be tempered a bit. So working together has to be the way.
Probably the more we collaborate and we talk one with the other, the best is.
Okay, so this is a great conclusion at this stage. May I propose that we try to tackle several questions asked in the chat. Initially, you addressed the diagnosis. We have one very interesting question. Does NT-proBNP have a good negative prognostic?
Yes. Again, a diagnosis of heart failure preserved ejection fraction in the presence of the normal BNP has to be questioned. It's hardly
crystal clear. On thanks, Charles. So what is the MRA of choice in heart failure now?
Sorry, Mr. Patrick?
I may add, is there an MRA of choice in heart failure now? So I guess the question relates to Spiro versus eplerenone, since these are the only MRAs approved for heart failure so far.
Yeah, I tend to use spironolactone, and only rarely, if I'm running into trouble, do I switch to eplerenone. As I said, I probably would love to use Ferro.
Okay. No, I wouldn't say that at this stage, because there are ongoing trials with finerenone in heart failure. So, so far, to the best of my knowledge, both Spiro and eplerenone might be used, although there are some differences in the label. As for instance, in my country, eplerenone might be used only post myocardial infarction. I used to be prescribed post-MI on downstream ephesus. It could be used in heart failure on reduced ejection fraction and with mildly reduced symptoms. So to sum up, I would say both might be used in HFmrEF, to the best of my knowledge, both eplerenone and spironolactone. Other question. Do you have an experience with Aquadex, slow continuous ultrafiltration device, in edema refractory to diuretics?
Short answer is no. I don't.
I'm sorry?
No, I've got no experience with that device. The experience I have in terms of using ultrafiltration or peritoneal dialysis for the management of heart failure has been unequivocally awful, terrible, and bad. And I usually find the nail not to embark on that.
Regarding drug regimen optimization, how can we optimize heart failure without adversely affecting patients' biochemistry, for instance, potassium levels? In other words, how do you manage potassium issues in heart failure and CKD patients? Should hyperkalemia or hypokalemia happen?
Hyperkalemia is rare, I think, unless we use unopposed diuretics. Hyperkalemia can be a problem. Luckily, we've got some binders, getting easier and easier to use, getting easier and easier to get reimbursed. But still a worry, still a concern. I think these patients need a lot of close monitoring, particularly advanced CKD treated with ACE inhibitors and MRA combination. It looks like SGLT inhibitors are also very good at protecting against hyperkalemia. That's the evidence that I'm seeing coming through. But they're still not a panacea, but they do seem to ameliorate the risk of hyperkalemia.
So thank you, Charles. Back to the dialysis questions. I have one question regarding vascular access. Do you have a preferred vascular access for patients with heart failure? In other words, because I guess my guess is that our guess is referring to increased output induced by the arteriovenous fistula. What are your thoughts regarding to increased cardiac output induced by the fistula?
It can be difficult. Certainly, the main driver would be blood pressure. So if they have low blood pressure, then we wouldn't create a fistula. If creating a fistula drives low blood pressure, then we'd have to tie it off, particularly if it causes high outflow heart failure. It's interesting to remember also that all these drugs that have worked for heart failure in the past are all vasodilators. And theoretically, actually, if you have normal or relatively preserved kidney function, creating an AV fistula would reduce peripheral resistance and improve cardiac output, cardiac function. So it has been advocated for many years that creating fistulas might be a good thing. Similar, I suspect, would run into the same problems that we run with hypertension and creating AV fistulas to control hypertension. That was probably an unmitigated disaster. I don't think anybody's actually ever done that seriously, although it's been proposed repeatedly. But no, the main trouble I find with heart failure patients on dialysis is their blood pressure.
Perhaps one last question related to diagnosis. What is the best time to do echocardiography for dialysis patients? Before or after dialysis session? Midweek or later, earlier? What is your routine practice, Charlie?
We try and do it on the non-dialysis day. So a Tuesday or a Wednesday, depending if they're Monday, Wednesday, Friday, or a Tuesday, Thursday. Midweek non-dialysis day.
Okay.
We're standardizing it.
So I have a couple of questions regarding SGLT2 inhibitors in dialysis. Some questions you already addressed, by the way, in your talk. The same applies for MRAs. So I think perhaps one question in kidney transplant. At what point would you introduce SGLT2 inhibitor in kidney transplant patients with proteinuria on CKD 3b4? I presume with heart failure. So any difference in the way you may treat CKD patients on kidney transplant if they become, if they present heart failure? Any way to treat that differently or not?
No, I'd say I try and think of transplant patients. Again, my true transplanting colleagues might get quite cross with me, but I just see them as CKD with a bit of extra immunosuppression. I would treat them the same depending on the level of kidney function and the level of proteinuria.
And before we conclude, I wish I may thank the EuReCa-M Working Group of ERE for having organized this e-seminar. Thank you for having attended it, and take care.